Hi, I'm Matthew Herzberg, and this is the Myopia Mindset. This is your weekly check-in for motivation, inspiration, and education on your journey towards success with myopia management. And for this episode, I am super excited. I've wanted to do this episode ever since I sat in a couple of awesome lectures at the last Vision by Design for 2024. And I was like, man, I really got to do this episode. And I am excited to introduce our returning guest, Dr. Cheryl Chapman. Cheryl is an orthokeratologist and a myopia management specialist and a fellow of the American Academy of Orthokeratology. She's also a past president of the AAOMC. She practices at Gretna Eye and Aesthetics, and she's a co-founder at Peak Pro. And joining us is Dr. Brandon Baartman. He is a board certified ophthalmologist at Vance Thompson Vision, where he specializes in LASIK, cataract, cornea, glaucoma, and vision research. He has done some amazing life-changing surgeries across the world in Ghana and the Indian Himalayas and Honduras, and he is the co-founder of Green Man Vision, Inc. Brandon, Cheryl, welcome to the podcast.
Thank you for having us.
Thank you. I'm excited to be here and joined by such amazing talent like Cheryl and yourself. This is really cool. I'm just honored to be here.
Thank you so much. And the genesis of this, as I alluded to in the introduction, Brandon, that started with your lectures at Vision by Design 2024. I was in the audience and I was blown away by, I'm not an optometrist. I grew up in an eye care practice, as a myopia coordinator, basically, before we had that term. But I was blown away at how much how much knowledge I had achieved over the years, because I was able to follow along with a lot of what you were saying. And I was so impressed by your stance on myopia management, and all of the different aspects as it relates to you as an ophthalmologist and your LASIK practice. And so I got in touch with Cheryl and I said, I got to have you guys on. So the goal of this episode really comes down to the fact that so many optometrists that I've met have a really difficult time cultivating and creating these relationships with, our partners in ophthalmology. At one point in time, myopia and orthokeratology was even kind of bad words in the world of ophthalmology. So let's start there. Brandon, I'll start with you. How did you first learn about myopia management? And then we'll bring in Cheryl and talk about how you guys cultivated that relationship.
Yeah, first, that going back to the lecture, that wonderful conference that Cheryl put together, she asked me to give these talks, and my first reaction was, what can I possibly offer this group of professionals that are practice in a almost parallel and oftentimes not clearly intersecting field of medicine. And it really helped me take a deep dive into what those intersections could be. And I really had a blast doing that. But to answer your question, where I first came across myopia management was in my residency training program. But it was very peripheral. Like it was akin to, in our line of training, it was akin to vision therapy, of which we get zero training, right? And myopia management really wasn't part of that either. It was kind of an awareness, okay, this exists. Typically, ophthalmologists aren't practicing that. And there's data out there if you want to go look it up. And so that was the extent during my training. And it really wasn't until I opened this practice in Omaha and none other than Dr. Cheryl Chapman came to my clinic when I still had 5 employees, and now we have 60, which is incredible. But we had 5 employees. We all packed into this little tiny conference room. Cheryl, do you remember that lecture that you gave us? And she presented and educated us. And I can honestly say I learned way more about myopia management in that little session than I had in the entirety of my eye training.
And Cheryl, was that common practice for you? Because like I know you personally, I know that when you set your sights on something, you go after and get it, and it is in your personality to create these meaningful connections. So obviously, you set out on a mission to talk about myopia in that context. So what was the inspiration behind doing that? Walk us through it.
So, you are in this field that is so important, and it's innovative, and it seems too good to be true almost. So you're trying to convince patients, hey, this is a thing that we can do, and you're just running into blank stares. And so you kind of have to think outside the box, like, how can we raise awareness? And one of the ideas that is often floated when you go to the conferences is create relationships with your pediatricians, with other, healthcare providers in your area. So I had created some lunch and learn type lectures that I delivered to various pediatric clinics and ophthalmology clinics around my area. And Dr. Baartman's clinic was one of those clinics. And it's important because, yes, I agree. And I think it's really eloquent the way Dr. Baartman said these are kind of parallel and often not intersecting, but they really should be intersecting in the sense that you need to have these two professions communicating and having these open lines so that we can talk about different cases and help each other. It's so obvious to an outsider that, of course, people who are going to LASIK clinics have a lot of high myopia in their family often. And yes, it makes sense that there should be interprofessional referrals, because what LASIK surgeon would rather have a -8 than a -3? Like none. Mm-hmm. And so the two can coexist quite nicely. And so, yeah, I wanted to make sure that I was doing everything that I could to grow towards my goal. And one of those pieces was outreach to other healthcare professionals in my community.
That's great. And Brandon, what was it like to hear that pitch from Cheryl? And it does myopia management, did it have like an appeal to you? Because I have tried to do this for optometrists when I was, over the years, when I was with J&J and even with the AAOMC, I would try to talk to ophthalmologists and say, hey, I know you can't do LASIK on kids. Is there value in doing something like orthokeratology on kids until they're old enough, to do LASIK surgery?
Yeah, I think her lecture really was eye-opening to me, and one of the quickest parallels that I drew in something that I was intimately familiar with was wait a second, how is this so different from the way that we care for patients with keratoconus and cross-linking now? You know what I mean? And so they're frequently in our LASIK screening clinics, and we have to find them, and we work with optometrists once the corneas are stabilized to fit in specialized contact lenses. How that bridge has already been built, right? I mean, in cross-linking for so many ophthalmologists, one of the unique things about myopia management is it's not looked at the same way by ophthalmologists, and that's what I had a difficult time wrapping my head around once I heard Cheryl's lecture, dug into the data, realized one of my close, friends and mentors and now partners, Vance Thompson, is on the board of, myopia management products, right? I mean, these are real parts of our field that, I'm just excited to be, hopefully a conduit for more ophthalmologists to understand it, be a part of, the national meeting like Cheryl put on, and hopefully continue to grow that familiarity with that section of eye care, because I think it is important.
Yeah, and you mentioned this other way of thinking about it from the ophthalmology perspective. Can you go more into that? What was that other way, and where was the conflict exactly, if you don't mind?
Yeah, the conflict is, traditional ophthalmic surgical training is just that. It's surgical, right? I mean, the majority of our time in a residency training program is trying to learn, the steps of a cataract surgery or full thickness corneal transplant, and get as much exposure and experience to all of those things so we can go out and do it. There is almost no time unless somebody is is interested for some other reason to go seek out what are these, it's almost like Western and non-Western medicine. I mean, that is sometimes the way it is thought of in traditional ophthalmic training programs, and I don't think that that's right. I've come to understand the depth of the data associated with myopia management. I just remember an attending in residency suggesting ortho K was kind of like an attempt at braces for the cornea that doesn't really work. And that was the extent. And that was a cornea specialist. And so, that I think there's probably an element of my turf, your turf type of thing that I don't know that for sure. But if I were to venture a guess, it probably has to do with, where should these patients wind up? And I have my own opinions on that. And I bet you guys could guess what they are, but I think they probably differ from a lot of ophthalmologists. Would you say that's true, Cheryl? Do you think 100%. That that's probably right?
Yeah. Okay. Oh yeah. But it's shifting, right? So, what I see, and I'm going to make a very huge generalization here, which obviously is not always true, but I think that there's a difference in the age of the ophthalmologist based on like kind of what their thoughts are on that. I think often in general, the older an ophthalmologist is, the more they've had the training or the cultural sense of that difference between the two professions and the turf wars kind of thing. I've noticed in my interactions as ophthalmologists are getting younger, I'm getting older, the ophthalmologists are getting younger. They're more open to co-management. They're more open to working on problems together. There's an ophthalmologist in town who saw one of my ortho K patients for a surgical procedure. He's oculoplastics. And when he found out that she was doing ortho K, he was like, no, stop that immediately. And the patient left, and she had an appointment with me that afternoon. The patient left, and he walked across the hall to an associate OD that's in the clinic, and he said, what is this all about? And she said, no, here's the data. And he absorbed that data, and he's younger dude, okay, younger guy. He absorbed the data, listened to what she had to say, called the patient back, said, I was wrong. I thought that was pretty cool. Like, you, in the old days, you wouldn't hear a story of an ophthalmologist calling a patient back to say, I was wrong. But you're getting a whole different way of the way that doctors are communicating with each other, the way that they're communicating with patients. And so, now he's totally on board. Now I get referrals from him for high myopes and kids whose myopia is too high based on their age and they're progressing. So it's nice. It's nice to know that there's a shift in the way that people are thinking about it. And it really opens up a lot of doors. Like now's a really, really good time for doctors who are interested in creating these relationships with their ophthalmologist, because I think the time is right in the sense that it's ripe for the picking. Mm-hmm. The ortho K is no longer snake oil. It now is substantiated very well with a lot of peer-reviewed data. It's a real thing. It works. The World Health Organization is behind this. You have all of this information coming out that validates it. And so to say, hey, I can be your resource. Let me help you have access to the optometric community because I'm doing this. I can be there for you whenever you have a patient that needs this. And it's just a great time for optometrists and ODs to start working together in this sense.
Right. And I remember those, like old days, as you would put it. I remember the bad blood between ophthalmology and optometry. And a lot of those cases came from, the circumstances that you described of, an ophthalmologist essentially ruining the perception of orthokeratology specifically. I've heard so many stories like that. Brandon, what, is it the research? Is it the education? How have times changed? Like there definitely is that different opinion, that has come across. Was it just simply research and education that finally pushed that door open?
I think that's has a significant impact on it. I think, for me, I wasn't even aware that the data was there, and that's where I still think there's something else too. I
Mhm.
believe that it can't be just data, because somebody has to be interested enough to go find it, right?
Right.
Because that data is not being presented to us at national meetings. Now, I will say, with one caveat, I did see something, and I believe it was at this year's ASCRS. I saw something. It may have just been a section, but it was mentioned by a surgeon of myopia management in partnership with optometry. And so, I think that it's inching in that direction, but you're right. I think it's an awareness in the surgical world that this information gets like drilled into our heads all the time. There's going to be a shortage of ophthalmologists, right? It's looming. There's more retiring than coming into the field every year, and the number of patients needing eye surgery is skyrocketing, right? We have to be okay with a collaborative, and I would venture to say it probably won't stop at collaborative. I'm a big fan of integrative. I think that there's two aspects of the same field, and I think that younger ophthalmologists are warm to this, because they understand that their place and the best use of their training is going to be in the operating room, right? And they're going to have to depend and trust this other facet of eye doctors that can really bring a ton to the table. And I think that awareness is starting to spur maybe some programs even offering some education on it. I think that would be also really positive for both of our fields. But that's my suspicion, Matt.
Yeah. That's really interesting to hear you say that. I think that is something that is happening across, medicine and healthcare is, less and less individuals are interested in becoming, doctors. And so it's very interesting to hear you say that. What I want to ask you both about this question, because for a while, there was a huge fear that ophthalmology was going to take myopia management and basically corrupt it to a certain point, because they weren't going to be doing it correctly. And I've heard arguments that, myopia should stay with the optometrist, that the optometrist as the specialist should be focused on myopia management. It shouldn't become the domain of ophthalmology. But my impression is that this is kind of an all hands on deck kind of situation. However we can integrate or work together is the best, move forward. Cheryl, is this an unfound fear at this point? Was this just paranoia? Because, as Brandon's pointing out, there's a plethora of patients incoming. I don't think ophthalmology has time or opportunity or even the desire then to, I was going to say twirl the mustache, but Brandon, you have a mustache. Sorry, I was going to totally just make that joke right now. And I realized,
yeah, that's a good one. And I can try. I don't think mine's long. Actually, it is.
You need some wax.
Yeah.
Okay, so I have so many thoughts.
yes.
My question to you, Matthew, would be: is there a shortage of myopic patients?
There's no shortage.
There's
Cheryl.
no shortage. You could have every single eye care practitioner in the United States doing myopia management, and you'd still be busy. Okay. First of all, that's point one. Point two is the more people doing it, the more awareness there will be, and the more patients will actually want to do it because it's a thing, and that they know it's a thing. But second of all, why would ophthalmologists want to spend time on this? Because it's hard and it's not nearly as profitable as surgery, and they are trained to do surgery. Is it profitable? Yes. Is it as profitable as surgery? No. So I suppose there could be an ophthalmologist here or there who's interested in it enough to want to do it. But you could say the same thing. There are optometrists that if they're not doing it well, that's a problem too. Whoever's doing it should care about it enough to do it well. And that's the thing too. You shouldn't do something just because you see that it's a moneymaker or that you see there's an opportunity to do it because there's a need. You should pick your subspecialties based on the stuff that you care the most about, so that it's fun to do it, so that it doesn't feel like work. So those are kind of my main thoughts on that question.
Right. And Brandon, I didn't mean to, insult you with the mustache comment.
I'm not insulted. I'm honored.
So, how can we, shed that kind of, unfortunate, veneer that's been put on ophthalmology? Should we be actively embracing ophthalmologists? Like, I know that optometrists are approached by ophthalmologists and, that's the dinner conversation or the lunch conversation. What can we do? Like, what are ophthalmologists like? How should they be receptive if we have an optometrist wanting to approach an ophthalmologist about doing myopia management? What's the best way to do that?
Yeah, I think there's a couple of pieces, I guess, to my response. I think Cheryl said it really, really well, and the way that to draw an analogy in the surgical world. We welcome more competition, if you want, of people doing LASIK because it raises awareness. We like it when we see people have ads out there, even if it's not ours, because that's what happens when somebody advertises LASIK in our market, even if it's not us. Awareness goes up and our phone starts ringing, right? And so I think the high tide will raise all boats, right? And so the more people doing it, and that would be my perspective. I have no interest in this because I feel like I have found what I'm passionate about. But I don't know that from my perspective, I would tell ophthalmologists to stay away from it. I think you follow what you're interested in. If there are pediatric ophthalmologists that say, boy, I just, strabismus surgery isn't it doing it for me. I like the research and the data behind, because there's probably, I don't think there's a lot evolving in strabismus surgery. So if you want to be cutting edge, you're probably not, just a strabismologist anymore, right? You probably get into myopia management and other diseases of pediatrics. But, I think the best approach is to connect with an ophthalmologist and find out what they love to do. And so I think about how I connect with optometrists. I try to find out what they love to do. Do they love to fit sclerals? Well, my approach is I don't do any of that, right? I don't do that. But I know how important it is. And I want all of my patients who have keratoconus after cross-linking to have sclerals. And, that's kind of the approach I take. Figure out what each other's kind of like niche is and try to respect the line. There may be some overlap there, but find out how a patient benefits from the fact that you have a good working relationship and think of it from that perspective when you approach the ophthalmologist. And I think more times than not, they will be receptive to it, especially like Cheryl said, if it's a younger ophthalmologist who's more open to this, advanced way of practicing.
Yeah, I almost feel bad that I said that because like one of our previous board members who was on the board forever, Dr. Bruce Koffler, he is an OMD who's older and he's very passionate about our mission with myopia management. So I don't want to come off as saying it's very clear old or young, but there is a little bit of a change in thinking and peer pressure as well from colleagues.
I think that's right.
Go ahead. Go, Brandon. Go.
Oh, I was just going to draw another parallel. We know from the surveys among even just cataract surgeons, and I looked at this data that they put out every year, and the percentage of ophthalmologists being willing to utilize advanced technology IOLs is going up, and it's directly related to the younger age of those ophthalmologists, right? They find earlier in practice ophthalmologists are much more likely to consider using an advanced technology lens than older. And it really has to do with that older generation of ophthalmologists are probably the same people that, when they started practice, maybe optometrists weren't allowed to do a lot of stuff that they can do now, right? So they're coming from that background, whereas new ophthalmologists are very, very much accustomed to the advanced practice of optometry. So, that's what I think is also relevant to the discussion of why it's changing.
That's a great point.
Yeah, that is a great point. And it kind of, what I wanted to say too, I think is part of that as well, because I've noticed this in optometry, and it sounds like it's fine. It also exists in ophthalmology, but like optometrists coming out of school, the newer generation, they want to do more. The older generation of optometrists couldn't do as much, and the newer generation is not satisfied with just the status quo. They want to do more for their patients than what standard optometry has offered in the past. And I don't mean to be ageist or cast, throw stones at the past generations, but it is a function of life that the new then brings something different to the table, and then the old goes, phases out of whatever culture, system, discipline, profession, whatever it is. I think that's just a natural evolution. So, Cheryl, same question over to you. How can we prep optometrists then to approach their ophthalmologist? Because this is very much worth doing. I love the relationship that the two of you have built. And that, like I said, there's a whole inspiration behind doing this episode. I found that a lot of optometrists, because I have tried to hold the hands of some optometrists and take them to an ophthalmologist or a pediatrician, for instance. And so how can we prep optometrists who are in myopia management to even have this conversation?
Well, I think it's important for the optometrist to come prepared with regards to having maybe like a slide deck. But the slide deck should be simple, right? Nobody wants to be talked to as though they're having to learn a whole new thing. They need to be more just informational, and sort of introductory. So that's like after you get your foot in the door, to have something that you can actually deliver. And you need to be able to give value to them, to say how it can, kind of identify how it can help them. So your conversation with a pediatrician perhaps is going to be different than your conversation with an ophthalmologist. But I think too, like kind of identifying who in your community would be a good partner. Mm-hmm. And, make sure that you're giving as much as you're taking. Like, yeah, you want to have that relationship because you want to get referrals, but then also make sure that you figure out, like Dr. Baartman said, like what's important to that person and how can you help them as well? Like, I send Dr. Baartman a lot of patients. I send him cataracts, LASIK, keratoconus, glaucoma, superficial keratectomies. I send him all this stuff because I trust him and he's really great and his clinic is awesome. But I would not expect him to be receptive to me if I never sent him anything. So you have to be giving, if you want to receive. So yeah, I would say find ophthalmologists or pediatricians in your area that you feel like are more progressive, are, more present in the community. If they're advertising a lot, if they're at special events, if they do volunteerism, stuff like that, those are probably the types of people you want to be aligned with. And if you see them doing something that you identify as tangentially related to what you want to be doing, mm-hmm. then, reach out to them, drop by their office, bring cookies for their staff. We all have drug reps that come in all the time. And we know how we feel when those drug reps come in. And there are some that you really like and want to talk to. And there are some where you never want to talk to them. And a lot of it has to do with like how they treat you, how they respect your time, how they treat the staff, stuff like that. So you can definitely kind of put yourself in that mindset and treat them like you would want to be treated.
So I want to thank both of you. You are both my heroes. Seriously, like the fact that we got here because there was such bad blood. When I first came into this industry, there was such bad blood between these two sides. So
like 20 plus years ago.
Yes.
Long time ago.
So be it. Yes. But yeah, you are both my heroes. Thank you so much. Brandon, I totally forgot to do this at the top of the show. If anybody wants to get in touch with you online, reach out to you. If they have questions about anything in this episode, how can they get in touch with you?
Yeah, send me an email. I will gladly respond as long as it doesn't go to my spam. And it's brandon.baartman@vancethompsonvision.com.
Gotcha. And Cheryl.
All email goes to my spam.
You're just too popular. You get too many emails then.
I prefer to be reached on LinkedIn. Dr. Cheryl Chapman. Look me up on LinkedIn.
Definitely, definitely. And if you have found this episode of value, if you believe in what we're doing, consider supporting the Myopia Mindset. You can do so via our Substack. You will get, for basically the price of a cup of coffee each and every week, you'll get an extended version of every episode that we do, and you'll get a bonus episode each and every month. And you will also be supporting the mission because, like I said, we believe here that, myopia management's the greatest thing ever. And if you want to see more awesome guests like Dr. Baartman and Dr. Chapman, by all means, help us spread that message. So, consider this an open invite. I'd love to have you both back on. Cheryl, you're like one of my returning champions at this point.
Thank you for having me.
So thank you so much.
I'm just thrilled to be a part of it. You did a great job, Matthew and Cheryl.
Thank you.
Your insights are incredible. I learned something every time we talk. So I'm just tickled to be here.
Awesome. And for everybody else, we will see you at the next one.